Hey, Tony, how are you?
Really well, thanks.
Good to see you. Close your other tab that's got the music playing in the background.
What tab is that?
Got to be the one that's open with the.
There we go.
There we go.
The
Beautiful.
last presentation. Yep.
Awesome. Great to have you. I'd like to welcome Tony Juarez, physiotherapist from Sydney, Australia, to the stage. And I'm going to turn it over to you. Take it away, my friend.
Thank you very much. Those were fantastic talks that we just heard. I'll just share my screen here. I'm coming back. I'll share. Here we go. I did learn this.
Just a couple of hours ago.
Here we go.
All right. Load up. There we go.
All right. So this should fit in perfectly because we've had John explain what Dr. Ponseti Method actually is and illustrate that perfectly. We've had Maureen do a fantastic job of what great parent support should be like. And I hopefully will fill in what it is parents need to look for. So what roles people play depends on all the different states, where you are, what country. And so here in Australia or Sydney, at the Children's Hospital, it's obviously a team effort, and each different team member, this has been in flux. So Dr. Herzenberg was the first to inspire Dr. Belmore, who started doing the Ponseti Method here in around 2000 or just before 2000. So he was doing the casting initially, and then the physiotherapy team started supporting because we do all the plasters for other conditions, fractures, and in theatres, hip spikers. And the orthotists were involved with the bracing at that stage. So when I became senior in the team, we had a big meeting and things just changed. So the key point is that everyone doing the Ponseti Method is working as a team. So we all work together, and we've got a clinic where we do the Ponseti treatment. The surgeon's present, the physiotherapist is present, and so we can communicate together and we're all on the same page. And we always try and make sure that the parents get the same information from everybody involved. So in Australia, where I am, we do prenatal educations about club feet when they're diagnosed on ultrasound. We do the casting during the treatment phase. Doctors present next door doing follow-up appointments, which means he's on tap if we're running into any problems, and we can keep him up to date with how we're going and how we're progressing. And then when it comes to the bracing phase, we have more time than surgeons to be that support person, to be that person, that contact person. So we are that person here to provide that support. And then, in our team, so when we talk about bracing, and there are many different types of boots and bars, and then there is the KAFO, which I'll show you what that is, which is a brace that the orthotists make, which does a fantastic job for children that are older than 5 years that need to continue bracing, or just variants that can't fit boots and bars. So the diagnosis might be at the prenatal ultrasound at 20 weeks, or it might be after birth. So the referrals made to the hospital. So there are major centres that do the Ponseti Method, and we support all hospitals around Australia, in New South Wales and Australia, to try and make sure it's consistent, and we're all doing the Ponseti Method. We recommend to start casting 2 to 4 weeks of age. We find absolutely no difference, and we've shown that in the success of the treatment. And we do like children, so if they're born premature, we will wait until their term age or something around 3 kilograms. It's not an absolute cutoff. So as you've seen from Dr. Herzenberg, casts are done weekly, and usually at around 6 weeks, the foot is ready for the tenotomy. The majority need tenotomy. After the tenotomy is performed, the plaster goes on and stays on for 3 weeks. And then after that plaster comes off, the child is ready for boots and bars. Like Dr. Herzenberg said, if you don't have good flexibility after the tenotomy, then we will continue casting weekly after the tenotomy until the 3 weeks after the tenotomy. When boots and bars starts, 23 hours a day for 3 months, and then continue till 12 to 14 hours a day. We've seen pictures of the casting. Here in our clinic, we take off the plaster with these little benders, so we just rip it off. It takes us 1 minute. We like the cast to stay on so we know that it's been on and make sure that there's been no slipping. We also, after we take off the cast, the baby can have a bath, and the parents really enjoy this time. So this is the tenotomy being performed, and you can see the good ability to bend the ankle up, which is dorsiflexion, and the boots and bars. This is vital, and as Maureen pointed out, that we drill home to the parents every time they come for casting that it's going to be so important that you keep the boots and bars on for success, and it really is the key thing for success in managing club feet. So this has all been said. But when we've finished putting on the boots and bars, we follow up in 1 week's time. But they have our numbers, emails, and they can get in contact if parents are having any issues. If blisters arise, they can get on the phone and we can book them in the very next day or that day, depending on what time they call. And then we as soon as they're confident, we can leave them and then follow up at that 12 weeks in the boots and bars, the 3 months where they graduate to sleep time only from 23 hours a day. So they have us on tap, which is something different because surgeons, their time is much more, they're in surgery, they've got clinics, and very hard to be contacted compared to a physiotherapist. So managing relapse, this is the key. This is one of my passions. So how do you know there's a relapse? Well, basically you can't passively, which means you can't push the ankle up into dorsiflexion or abduction. So if either of those have become stiff, that is a relapse. So we try and show the parents what we mean by that when we measure this at every appointment. After the correction of the Ponseti Method, we take a Meglio score, which is measuring 6 things, but the key 2 features are how far can that ankle dorsiflex and how far can you abduct it, turn the ankle out. So the goal of treatment in Dr. Ponseti is to achieve a plantar foot, and as Maureen pointed out, most common form of recurrence is Achilles tightness, but the most common is failure to wear the boots and bars. So what is normal range of motion? So it can vary greatly. So in dorsiflexion, you can see the ankle can bend up anywhere from 15 to 50 degrees might be normal for a child, and the same with turning the ankle out, which we call abduction. 20 to 50 degrees is normal. When we're looking at older children walk, we look at whether they can get that foot down flat. So you can see in that where it says yes, they are, the big toe is off the ground. So that is indicative of someone who would benefit from a tendon transfer. And as we said, we have our surgeon, Dr. Gibbons, who's at the clinic at the same time, and we, he observes the children walking, and he would give an advice if he feels this is beneficial, depending on if they're having relapses and having complications. So this is an example. You can see that this is a very old photo when posterior medial soft tissue releases were done very frequently. And when I started, these children would still correct with Ponseti casting, even though that things had tightened up again. So you're looking at almost like brand new club foot with no in the beginning position with extra scar tissue due to the posterior medial soft tissue release. But it's still corrected with Ponseti Method. So you're looking at the range of motion. You can see this ankle cannot get neutral. And so if anything less than 0 degrees needs casting. With varus, we're talking about the heel and the angle that the heel is at. So if the heel is straight when they're standing with their foot flat, then that is 0. Anything where it is in varus needs casting. And it sort of coincides with if the ankle can abduct well to 20 degrees, more than 20 degrees, usually that varus is 0. So, club feet, we know it has a stubborn tendency to recur. Good initial treatment does not mean it's going to prevent recurrence. And the recurrence is caused by the same pathology. So doing the Ponseti method doesn't take away the pathology. We still have a muscle imbalance, weak muscles. And so all we're doing with Ponseti is stretching and putting the foot in a functional position, but we're not changing the function of the muscles. And so it can recur just because on the severe end, the people that have more weakness and imbalance, it drives the foot to get tight. Even though you might be compliant with your boots and bars, it still may recur. So improving the use of boots and bars, as Maureen pointed out, consistent education at the initial consult, each cast change, trying to reinforce that point, strict, clear bracing protocol, ongoing support, and regular follow-ups, and also bracing options when if everything is being done correctly and they're still having issues like blisters, or people have different conditions which change the whole shape of the leg. Some people only have one leg, and so you have to go to a one-leg brace. So this is the one-leg brace, which is called a KAFO, knee, ankle, foot orthoses. It holds the foot in the exact position you want to achieve. So you can bend those bars and you can have it bent to 20 degrees dorsiflexion and have it turned out 20 to 30 degrees. So, you can have it. It's a very effective. The only downside is that you can't move your knee and you can't move your ankle. But in certain circumstances, this is better than leaving the foot to just get bad with no bracing because boots and bars are not working. So this is a child actually who had a neglected club foot, but at any age, if someone gets a recurrence, whether they're 12 or whatever age they are, we always try Ponseti first. And so I urge everybody to think that way. But before we start casting for treating, we make sure that the parents know that bracing is essential. Otherwise, keeping this correction is not going to be effective, and you may well have not started and gone through the whole process. So the bracing is such a key element in educating parents to brace. So the casting, if parents accept to do the bracing, as we've described, then the casting is trying to achieve, firstly, it's exactly the same as the baby cast, turning the foot out, trying to achieve that 20 to 30 degrees ankle abduction. And then once you do achieve that abduction, we can go to short leg serial casting, which does achieve the dorsiflexion as well. In some cases, after the casting, they might still require a tenotomy or a tendo-Achilles lengthening. We're talking about the older children here that are over 5 years of age. But when they're under, again, we will go through the process of first achieving the abduction and then trying to achieve the dorsiflexion with short leg casting. And if a tenotomy is required, then Dr. Gibbons is present to do that and book that in. And obviously, with children that have a strong muscle imbalance, the tendon transfer is highly beneficial, and that is done at an appropriate age so the bones are ossified enough. So in summary, basically, more than 10% of club feet do relapse, even with best efforts to use boots and bars. And because they're more on the more severe end of the club feet, and I'm not excluding all the groups, so all of ours are grouped in together. So we've got arthrogryposis, we've got, which obviously recur a lot more, atypical club feet, which recur a lot more. And so your regular club feet don't relapse as much, but they still do relapse even if you use boots and bars. And I would say that the Ponseti method works with, any age group, with any, comorbidity. So I would definitely use Ponseti method first. What's the harm? If you do it and it doesn't work, then you have surgeries at your disposal. And the bracing is the key to success.
Great.
And here we go.
Excellent presentation. Appreciate it. We've definitely got some questions. Absolutely, I want to get to those. Dr. Herzenberg, for your relapse casting, do you use long or short leg casts?
Always long. So that's why I didn't really talk about that, because Ponseti, as Dr. Herzenberg pointed out, can only be long leg Ponseti to get the abduction. If you only have a relapse of the Achilles, then we would only do a short leg cast. So if you have full abduction of the ankle, we would only be doing short leg cast in say a 5-year-old, a 10-year-old, or whatever age. But if you have a relapse and you don't have the full abduction and varus, then you need to do Ponseti casting first.
Awesome. Amy asked, her daughter's 9 months old and stands on the inside of her foot, so the ankle is bent inwards. Is this normal for clubfoot babies when learning how to stand?
So you're saying she's rolling in on the inside of the foot. So it may be, and she may be a little bit over flexible in her feet. So sometimes there's a number of things that certainly should be looked at, but it's not a problem. Having a flat foot is not a major issue, but the thing is the severity of that. So some people are hypermobile, and by putting the boots and bars at 60 degrees, turned out that's a little bit too much for them. So then the person bracing might reduce that to 30 degrees and to not put such a big stretch. But, it's not a problem to have flat feet.
Okay. Sam said, despite following all the treatment protocols, are there any reasons for kids not being able to tolerate the brace? And I know Ruth chimed in, but I was interested in what you had to say.
So there's always one, we see at least 70 new babies a year, and there's always one or two that just have a different, personality and are just much more challenging. And so they do they fight it more, and they have blisters, and we just work with the family in trying to reduce the blisters by using Duoderm, like special second skin that you put over the top, or even just trying different bracings, extra paddings, and we're going to hear Ruth speak, who's going to have lots of options on bracing. But yeah, we work with them to make that successful, but the majority have no problem. Mm-hmm. But there's going to be a few that will give you problems.
Sure. As Maureen said, every child is different.
Absolutely.
One child might tolerate, another one might not. Janine asked, are there any stretches or exercises? She's a physical therapist. So, are there any stretches or exercises that as a PT she should not do during the boots and bar phase? Squatting, stretches, any that she should not do?
There's no contraindication for anything. So we highly encourage everything. I mean, Dr. Ponseti, he said it's really good, like Maureen pointed out, the dorsiflexion and abduction. If they can have good dorsiflexion and abduction, they can wear their braces comfortably. Dr. Ponseti, he said, what sports or what things could they do? He said rollerblading. That's if they're safe and at the right age, because you're turning your foot out, and I guess, but there's no specific exercise you have to do. If you can comfortably put your boots and bars on, it is doing the stretching for you. Mm-hmm. The checking the flexibility is the thing that Maureen pointed out. If the parent has that knowledge, they're the first to raise the red flag when they're struggling to put on the boots and bars and things are getting tight.
What angle is the knee held for full leg casting?
Yeah, great question. I used to do 90 degrees like the babies, and then I had my first child. He'd already had an Alizarov frame treatment. He had full posterior medial soft tissue release. This boy was 8, and he also had an undiagnosed Marfan syndrome. And so after the first long leg cast at 90 degrees, his knee was contracted. I had to do an hour of physiotherapy just to straighten his knee. So we modified that to about 40 degrees to 30 degrees of knee flexion, and the cast never slipped. He could walk in them if you post the heel. And so we call it the Ponseti walking cast for the older kids. And so roughly about 40 degrees at the knee.
Okay. For Mindy, physical therapist, asked, for relapse, do you do nighttime positioning only or back to 23 hours?
For relapse, no, you go only to nighttime. So, it's really just getting back into your routine of bracing. So if you relapse and you're 6 years of age, let's say, you're going to do another year of bracing. That's our protocol, and then we will try and stop bracing and see if there's any relapse after that.
Gotcha. There's some discussion also in the chat with Danielle, who asked the question earlier about a blister, about sores, and her child has, Dr. Herzenberg and Ruth are both chiming in. She went to an ADM, and she has a sore under the on the front of the ankle, under the middle strap on the right club foot. So there's one in front of the foot, but also under the middle strap under the right club foot.
Yeah. So my partner in crime, Alison, deals with our ADMs, and she basically has made it very clear: if you don't have more than 20 degrees, 25 degrees, 20 degrees of dorsiflexion, you're going to run into trouble with the ADM. So the ADM is for the kids that have really good flexibility. So maybe more casting to get more dorsiflexion might reduce that rubbing on the front of the ankle.
Fran from New Zealand asked, our son drags 1 foot when walking. He's almost 3 and in the boots and bar for bilateral club foot. Is it normal for club foot children to walk unusually or trip more often?
So again, it's that question of variability. So no, children with club feet can walk normally. So that gait should be assessed. There's many causes of someone dragging their foot, but at the same time, it may be quite normal. It might be just his way of walking at the moment, which is only a small phase, and then it will change.
Sam, also a mom of clubfoot child. Do you have many kids that have leg or calf cramping? Do your kids?
No, I've never seen a muscle spasm or cramp during casting. No.
Okay. Some continued discussion here. Any other questions coming in from the audience, or if anyone would like to grab the mic and come up? We got Allison Chivers coming up. Okay, awesome. That's what I like. I like when people want to come up to the stage and be with us. That's beautiful.
Oh, no, that's okay. I just wanted to address Danny. I work with Tony, okay, but obviously I'm not in the room with him today.
That's okay. You are now.
Right, that's right. I just wanted to address Danielle's question about the pressure on the strap. One thing that we have found, I'm not quite sure if she's done this yet. So there is 3 straps. There's one around the ankle that goes through a tongue, like a little feeder. There's the one, the next one down that goes around the ankle, and then there's the one at the front. What I tend to do is it's got a keeper. The one that's around the ankle, goes around it, that's in the keeper, I don't put it through the keeper. I just tend to find that when I put it through the keeper, that and the next strap rub, they kind of push into each other, and that can cause a problem at the front of the foot there in the anterior ankle. So that may be the problem. So I would say take that first strap that's around the ankle out of the keeper and just put it around. It's got the Velcro on it. It's the one that isn't the one that's through the buckle. And you may find that that will help, because then what happens is that one with the Velcro just tends to slide just over the top of the next one. It doesn't dig in together. That may be the solution to the problem. It was the solution to the problem for our children. We've virtually had none of those issues since then, but I could be misinterpreting where that sore is. So I could have answered a question that wasn't, I could have answered something she didn't ask, but that's my solution if that is the problem.
That's awesome. That's awesome. Thank you so much. And you're more than welcome to stay on stage since you work with Tony and me.
Oh, that's fine. I didn't know how to get off stage, so now I'm stuck. I'm stuck on. I'm looking around going, where's the exit button?
I can get you off if you want. I mean, you know.
No, I'll stay on for the moment. Okay, see how it goes, and then I'll get off.
Heather is a physical therapist and clubfoot mom. What age do you brace until, and do you do anything for older kids different than boots and bar?
Yes. So we brace until 5, and the brace that we use differently for when they're over 5 is the KAFO. Now, the ADMs do go a little bit further, and so we might be able to size, say, someone who has a single unilateral club foot, we may use till 7. Okay, so we might continue with the ADM, but when someone has a very stiff recurrence and recurs older, they usually get a KAFO, which our orthotists custom make.
Fabricate, yep. At what age do you usually recommend tendon transfers?
So they have to be older than 2.5, so about from 2.5 on. So it really doesn't matter whether they're 3, 3.5, 4, 5. And sometimes it's really when that they are unable to get that big toe down. So that usually shows up earlier, and then we're waiting for the time when they're old enough to do the tendon transfer. Or it might be something that pops up a bit later, and we can do it, like we've got a couple that are 5 that are getting their tendon transfer. So really any age.
Okay. How does the ADM work if it doesn't go above the knee?
It uses 2 springs. So there's one spring that pushes out into abduction, and there's another spring that pushes up into dorsiflexion. I'll be honest here, the spring into abduction is not as great as the boots and bars. So it's probably about 30 degrees that it holds the foot at. The spring into dorsiflexion is actually greater than the boots and bars, so it's 15 to 20 degrees on the standard spring. So, look, it doesn't replicate exactly a boots and bars, but it's like, I think, the chicken and the egg. Which one do you need? When we walk, we don't walk in abduction, okay, but we still maintain dorsiflexion of our foot. So I think that's how the ADM is. It's pushing them out into some abduction, but into more dorsiflexion. So, look, I guess I'm not here to say whether it's, I'm not saying it's better than boots and bars. I'm just saying it's another tool that we have been using, primarily with kids with unilateral feet. Nothing special about their feet. It's just it was a parent choice. Our parents actually pay for them. They don't pay for the boots and bars. So it was driven by parents wanting to use it, and I guess we just decided to go with it if they wanted to spend the money. And we always told them that if it wasn't successful, we would be going back to boots and bars. So they're totally aware that if it's not successful for their child, they'll go back to boots and bars. Look, to be honest, we've got 70 families using it, and we've had no one go back to boots and bars. We've still had a couple of relapses using the ADMs, but no greater than what we've had with boots and bars. And we've also had the same problem. The biggest reason for relapse is not wearing the boots and bars or wearing the ADM. So it's pretty well the same root cause. And to be fair on our parents, there's many reasons why parents are able to continue using a bracing method, and sometimes it could be our fault, it could be lack of support, or it could be, hospitalisation of that child. It could be family breakup where the child's going between a few different places with parents, so there's no consistency. So there's a lot of reasons, very unsettled child. So there's lots of reasons why parents are not continuing with the bracing. It's the same reasons. If you don't wear your ADM, you'll get a relapse. If you don't wear your boots and bars, you'll get a relapse. So it's just another tool.
Wear the brace.
Absolutely. That's right. And
right.
as clinicians, we need to support them wearing the brace.
That's right. Thank you so much. You guys are great. Any questions we didn't get to, again, they'll be answered after the event. I'm going to stop. I'll see Ruth in the other room. I appreciate you both. Thanks so much.
Thank you.